Hello, my name is Jean-Jacques Kiladjian, and I will present you the results of the ROP-ET study that was performed in patients with essential thrombocythemia. You know that this disease is characterized by an elevated platelet count, a risk of vascular events, thrombotic or hemorrhagic events on the short term, but also on the long term of evolution to myelofibrosis or acute leukemia. This disease is mostly treated currently with hydroxyurea or anagrelide, drugs that are efficient, but that induce, because they have to be used for lifelong, some resistance or intolerance in many patients after a while, after a few years of utilization. So we need alternative therapies. And we tested in this trial the monopegylated form of interferon alpha, the ROPEG interferon alpha 2B, to see if patients who were resistant, intolerant, or ineligible to all available therapy could be treated efficiently with this drug. So main eligibility criteria were patients with ET, requiring cytoreduction, intolerant, resistant, or ineligible for all the drugs that are locally approved, because this was a European trial performed in 10 countries that have sometimes different indications for the drug. And patients received ROPEG interferon alpha 2B every 2 weeks for a total of 36 months. The primary endpoint was a combined endpoint. Patients should have a durable, meaning at least for 3 months, a hematological and clinical response after 12 months. And this included peripheral blood count remission with platelets below 400,000 and leukocytes also normalized below 10,000, absence of thrombotic hemorrhagic events or disease progression, and symptoms or improvement as measured by the MPN symptom assessment form total symptom score. The observed response rate at 12 months was compared with a historical rate of 40% because this was a single-arm study. The planned sample size was 170 patients, but indeed we could enroll 132 patients, and I will give you the results based on this population. The dose escalation was as follows. The drug was started at 125 micrograms every 2 weeks and increased to 250 after 3 months in case of non-response, and could be further increased to 500 micrograms every 2 weeks after 6 months in case of no response. So 132 patients were enrolled. Most of them had a JAK2 mutation, 60%, but also 27% had a calreticulin mutation. Patients had various risk categories according to the IPSET stratification score, ranging from very low to high-risk patients. Most of the patients, 81%, had resistance or intolerance to previous cytoreductive therapy, including 25% completely resistant to the previous therapy. And indeed, the primary results was met, and ROP-ET study met its primary efficacy endpoint with a rate of primary response of 48% at 12 months. Remember that this had to be better than the 40% historical rate. If we break down by the various components of this primary endpoint, the durable complete hematological response was achieved in 65% of the patients. 96% didn't have hemorrhagic or thrombotic event, 100% all the patients, none of them had disease progression, and durable improvement in symptoms was also observed in 84% of the patients. The median platelet count decreased from starting at around 580,000 to 460,000 after 3 and 6 months, and then 300,000 after 9 months of treatment, remaining stable around 300,000 at 12 months. In addition, the median leukocyte count also reduced very rapidly from a median at baseline of 7.35 to 5,000 after 3 and 6 months of treatment, remaining stable until the 12 months endpoint. The disease symptoms also improved in more than 87% of the patients, and in terms of tolerance, it was very good. Although a very high number of patients had an adverse event, 73%, serious adverse events was recorded only in 1 of the patients, less than 1%. And most of these events were of grade 1 in 70% of cases. Among the adverse drug reactions that were observed in more than 5% of note is the elevation of hepatic enzymes observed in about 10 to 15% of patients, usually of grade 1, and resolving after a few months of utilization. Indeed, dose reduction was required because of a treatment-related adverse events in only 11% of patients and dose interruption in 10% of patients. Of note, only 2% of the patients had to stop the treatment because of treatment-related adverse events. So altogether, after 12 months of treatment with ropeginterferon alpha-2b in this phase 3 ROP-ET trial, it met its primary endpoint in terms of durable disease response that included not only hematological remission with normalization of blood counts, but also absence of disease progression, absence of disease-related complications, and improvement of symptoms. There were good safety findings, maybe because of the low starting dose that was very well tolerated, but we still have to pay attention to the elevation of hepatic enzymes. And indeed, ropeginterferon alpha-2b appears to be a good therapeutic option for patients with ET who require cytoreduction but cannot receive the other available therapies. I would like to thank all the investigators and the patients and their family who participated in the trial. Thank you very much for your attention.